Hi, everybody. Here we are on chapter 41. This chapter is on obesity, and obesity is one of the main issues. It is an excessively high amount of body fat or adipose tissue. It's a major health problem um, because it increases the risk of numerous other diseases such as diabetes and cancer, and it has become a chronic state in the United States. Um, so when we talk about obesity, we talk about a patient assessment. The body mass index, or the BMI, is the classification of weight. We talk about waist circumference, the waist to hip ratio, and a determination of the body shape. The most important part of your assessment is to determine where the patient falls in all of these. BMI is one of the most important measurements that we look at. So here is a chart, a BMI chart, and I think probably everybody is looking at this now to see where they fall on this BMI chart. So the BMI provides an overall assessment of fat mass. It must be considered in relationship to the patient's age, gender, and body build. We wouldn't expect the bodybuilder to have the same BMI as the librarian. We wouldn't expect the older adult to have the same BMI as the teenage student. So it has to all be considered in conjunction with where you are in life. So in general, body mass index is weight over height. Underweight is a BMI of less than 18.5. Normal BMI is 18.5 to 24.9. Overweight is 25 to 29.9. Obese is considered greater than 30. And then severely obese is greater than 40. Waist circumference is another measure that we use. People with visceral fat or truncal obesity are at an increased risk for cardiovascular disease and metabolic syndrome. For men, this is a waistline that's greater than 40 inches. For women, it's a waist that's greater than 35 inches. We also use a waist to hip ratio, and this is a method of describing distribution of subcutaneous and visceral adipose tissue. So the waist measurement, hip measurement is less than 0.8 is optimal. Greater than 0.8 is at risk for health complications. We also look at body shape. Body shape, apple-shaped body is fat located primarily in the abdominal area. That's considered an android obesity. Pear-shaped body is fat located primarily in the upper legs, and that's a gynoid obesity. And we have an example of gynoid obesity, pear-shaped. More than 35% of adults in the United States are currently obese. This will reach 50% by 2030, unless Americans change their way. 68% of adult Americans are within the overweight obese category and most common nutritional problem. It is also the second leading cause of preventable disease. Smoking is the number one leading cause of preventable disease in the United States. The processes leading to and sustaining the obese state are complex. If it was simple, we'd probably solve the problem. But body weight beyond physical requirements and abnormal increase in the proportion of the fat cells are main causes. So this talks about the increased number or hyperplasia and the size or hypertrophy of adipocytes. So this talks about adipocytes or hypertrophy is a process by which adipocytes can increase their volume several thousandfold to accommodate large increase in in lipid storage. So your fat cells are able to accommodate and grow larger, and then pre-adipocytes are triggered to becoming adipocytes, primarily in the visceral or in the intra-abdominal area and the subcutaneous tissues. And so this is also greatest from infancy through adolescence. And that's where we're seeing a lot of our country's issues is with the youth of our country. So there's strong studies of evidence of significant genetic and biologic susceptibility factors that are highly influenced by the environment, which means it's genetic, or it's suggested that there's a big genetic factor with this. So a number of genes have been identified as being linked to obesity. This talks about a strong link between the FTO gene and the BMI. The FTO is the fat mass and obesity associated gene. People with 2 copies of a certain allele at the FTO gene weigh 7 to 8 pounds more and have greater risk of obesity. Research has focused on processes that control eating behavior, energy metabolism, and body fat metabolism. And so knowing how appetite is triggered and energy is expended provides important information for understanding obesity, as well as specific targets for the development of drugs. Wouldn't it be nice if we could just start taking a drug and it would solve the problem? So in a nutshell, here's a picture of how hormones and peptides interact with the hypothalamus. The hypothalamus, the gut, and the adipose tissue synthesize hormones and peptides that are inhibitory or stimulate the appetite. The hypothalamus is the major site for regulatory appetite. The neuropeptide Y produced in the hypothalamus is a powerful appetite stimulus. When it's imbalanced, it leads to overeating and obesity. Hormones and peptides produced in the gut and the adipocyte cells affect the hypothalamus and have a critical role in the appetite and energy balance. So this slide talks about leptin and how leptin is secreted from the adipocytes when they fill with fat. And it talks about a genetic deficiency of leptin causing extreme obesity. In obesity, the level of leptin is actually increased, which has raised the question that obese people are sensitive to leptin, which is a possible cause that includes failure to produce enough leptin receptors, or production of the receptors are faulty. Ghrelin is the hormone that regulates appetite through the inhibition of leptin. And ghrelin is a gut hormone. It's in the fasting state, ghrelin is increased. It acts in the hypothalamus by working on rewarding the system that triggers overeating. Ghrelin is thought to play a part in compulsive eating. In gastric bypass surgery, ghrelin decreases significantly, which helps to suppress your appetite. So 2 major consequences of obesity are due to the increase in fat mass and to the production of adipokines. And so contributing to that are insulin resistance and atherosclerosis, and then disruptive immune factors and predisposition to certain cancers. Environmental factors also play an important role in obesity. In today's culture, there's greater access to food, particularly foods that have poor nutritional quality. Prepackaged and fast foods and soft drinks, proportion sizes have increased tremendously. It's also expensive to simply go shopping and buy quality food. The CDC has developed visual programs that demonstrate how proportions have increased over time. Let's see. So people also use food for many reasons. Associations begin in childhood. The sense of of being satiated can be compromised. I know I sit here and eat when I'm working at the computer, sitting in front of the computer. I like to call it mindless eating, but eating is social and often associated with pleasure and with fun. So there are some risks that go along with obesity. Health problems occur at a higher rate, spending 42% more on healthcare costs with obesity. The medical cost of an adult obesity in the United States is difficult to calculate, but it's estimated that it ranges from 147 billion to nearly 210 billion per year. And the bulk of the spending is from treating obesity-related diseases such as diabetes. The mortality rate as obesity, the mortality rates rise as obesity increases, especially when obesity is associated with visceral fat. For obese persons, mortality rates from all causes, especially from cardiovascular disease, are increased by 50% to 100% above those persons with normal BMI. And being overweight in midlife, once thought to have fewer health consequences than being obese, confers a 20 to 40% increase in mortality rate for both men and women. Most conditions will improve with weight loss. So when I was working on my master's degree, one of the things we did as a team was a paper on childhood obesity, and one of my team members was actually traveling in Europe. And I asked her if she would look around and see what the Europeans were doing about their problem of obesity, and her return comment was they don't have a problem in Europe because they walk more, they have more exercise, they don't tend to overeat. My daughter was traveling last year. She went to Italy and then she went to Brazil, and she forgot to carry a swimming suit with her. So both hotels that she was staying with had hotel versions of swimming suit, but they didn't offer in her size. They only had very small size suits. She is a hefty girl and fits into our society, fits all of these obesity issues, and they simply didn't have large size swimming suits. So very interesting. It is a unique problem to the United States. All right, so here's a picture. A picture is worth 1,000 words. Just kind of representing some of the health risks with obesity. Cardiovascular problems. Obesity is a significant risk for cardiovascular problems. Android obesity patients are greater at risk because of the increased LDLs and the decreased HDLs. They also have higher triglyceride levels. Obesity increases the circulating blood volume, abnormal vasoconstriction, and increases inflammation, which damages the blood vessels. It also increases a risk of sleep apnea, which raises blood pressure. There's also an alteration in lipid metabolism, which causes hypertension and increases the long-term risk of heart disease and stroke. And again, that risk of chronic inflammation throughout the body and the blood vessels especially. Diabetes, type 2 diabetes. Obesity is the major risk factor for developing type 2. More than 80% of people with type 2 diabetes are obese or overweight, especially that visceral fat. It increases the resistance and glucose intolerance, which makes treatment for diabetes less effective, that insulin resistance type. It's interesting because a reduction of 7% of a body's weight can actually decrease the risk of diabetes by 58%. We also see gastroesophageal reflux disease, GERD. We see an increase in gallstones. We see an increase in non-alcoholic steatohepatic disease, which is fatty liver, a non-alcoholic version of fatty liver, and that can be improved with weight loss. Sleep apnea, snoring and hypoventilation comes with obesity. It also reduces the chest wall compliance and increases the work of breathing and decreases the total lung capacity and functional residual capacity. We also see stress on the weight-bearing joints, the knees, the hips. Again, obesity triggers inflammatory mediators. We see cartilage deterioration and an increase of hyperuremic and gout changes. I think we talked about gout last week, or the last time we were together. Obesity is one of the most important known preventable causes of cancer. Breast cancer, endometrial, kidney, colorectal, you can read those, but about 20% of cancers in women and 15% in men are attributed to obesity. And there's really not a reason why. Nobody really understands that, but the statistics are there. There's also the psychosocial problems that go along with obesity, and those include low self-esteem, social isolation, depression, discrimination in employment, education, and healthcare. And I will tell you that my daughter is a big girl and has been most of her life, and I've seen her go through the low self-esteem, the depression, somewhat of the social isolation, although her personality has kept her from that, but it's there. So when we talk about nursing assessments, we have to rule out any kind of physical conditions that may be causing or contributing. We also need to be very sensitive to how the patient is feeling, be non-judgmental, clarify the rationale for inquiries about weight, dietary habits, and exercise, address patient concerns. My daughter actually went to the doctor when she was about 16 years old, and the doctor looked at her and told her she needed to try Slim Fast. And to this day, she tells me about that. Interesting that she remembers that. Make sure that when you're working with these patients that you explore any kind of genetic and endocrine factors that might play a role in weight gain and obesity, things like hypothyroidism, hypothalamic tumors, Cushing syndrome, hypogonadism for men, and polycystic ovarian syndrome for women. We also will evaluate lab values, things like that. We're going to take a health history, look at the time of obesity onset, the disease related to any kind of metabolism of obesities, any kind of drugs, and then we'll do an objective evaluation. I think we already talked about a lot of this in the previous chapters. Overall goals, we want to modify eating patterns, participate in regular physical activities, achieve and maintain weight loss to a specified level. We want to minimize and prevent health problems. Obesity is one of the most challenging health crises in the United States. It is a chronic disease state. Regaining weight often occurs, and lifelong management is indicated. Healthcare providers are often reluctant to counsel patients about obesity for a variety of reasons. Number one, because it takes a long time to do that. It's not always successful. Reimbursement for weight management services is not high, although that might be changing, and many providers do not feel knowledgeable about that type of medicine. So treatment begins with patients understanding that their weight history and deciding on a plan. An average weight loss program results in about a 10% reduction of body weight, and this is associated with health benefits. They're going to start seeing that with 10%. Exploring the motivation is key. We like to see a supervised plan of care, and successful weight loss requires short-term energy deficit, and then long-term behavior changes. Restricting dietary intake to below energy requirements is effective, and this includes food from the basic food groups for a weight loss of 1 to 2 pounds a week. Reduce calories from 5 to 1,000 calories a day. So we want to see in adequate quantities of fruits and vegetables, lean meats, fish, and eggs. We want to avoid fad diets because with fad diets, often body water is lost, but not fat. So success also depends partly on the amount of weight to be lost. And again, motivation is essential. Eating behaviors need to be examined. Why are you eating? Goals need to be realistic and healthy. It's not realistic to expect that you're going to lose, what is today, November 4th, 20 pounds between now and Christmas. That's not a realistic goal. But if you could possibly lose 1 to 2 pounds a week between now and Christmas, you might possibly lose 5 to 10 pounds before then. We also need to look at things like portion size. Foods can be weighed on an everyday objects that can be on scales. You have things that you can measure by. For example, a baseball is the size of a serving for vegetables or fruits. The person's palm or the size of a deck of cards is the serving of a meat. A thumb or 6 dice are the servings of a cheese. There are also all kinds of professional organizations and not professional that will help. Calorie density is important. 2/3 or more of the person's diet should be plant-sourced foods, and the other 1/3 from animal protein. So 1 portion of animal protein is 3 ounces. 1 portion of chopped vegetables is 1/2 cup. And it's also important that appropriate amounts of water are consumed with meals. An essential part of weight control program is exercise. So we want to see daily exercise, 30 minutes to an hour. This can help diminish the appetite. It reduces the waist to hip ratio and helps maintain weight loss. It doesn't help if you're a weekend warrior and sedentary during the week. That's sometimes even non-beneficial because you don't feel good with that. That can be harmful. The assumption behind behavior modification is that there's a learned disorder caused by overeating. And the critical difference between an obese person and a non-obese person involves cues that regulate eating behavior. I can tell the difference between when I'm at school and when I'm at home. When I'm at home, it's nothing for me to get up and walk to the refrigerator and get something to eat. When I'm at school, I don't have a refrigerator. So my behaviors are different. I do have a lunchbox, and I tend to overfill that, but that's a different problem. So we have useful basic techniques. We do self-monitoring. We show what and when foods are eaten. We can also keep a food diary. We have stimulus controls. We separate events that trigger eating from the act of eating, and those can be called emotional events for some of us. We have rewards that we can place that are non-food incentives for weight loss. And sometimes we even consider things like getting out of the office or getting out of the house to take a walk on a nice day as a reward. We need to encourage persons to join a support group of other obese persons, and they don't necessarily have to be obese persons, just persons who are receiving help to modify eating habits. And this slide is suggesting self-help groups are available, such as TOPS, Take Off Pounds Sensibly, and Weight Watchers, and I would highly recommend Weight Watchers. They have a very solid program and lots of support things to help. This slide tells you to never do drugs alone. Well, maybe that's not what it's telling you. I think it's telling you that drug therapy is not the answer. You use drug therapy along with other things like diet and exercise. Used only in conjunction with calorie reduction diets, exercise, and behavior modification. That was the point. Still, don't do drugs by yourself. Appetite suppressing drugs are sympathomimetic amines, suppress appetite by stimulating the central nervous system through increased norepinephrine. These are amphetamines. They're high abuse potential. They're not recommended or approved by the FDA. And then we have non-amphetamines. These are recommended for short-term use only. So some examples are, and I'm not going to pronounce them all. Phentermine is one that is a prescription drug. Tinuet is another one that's prescription. Well, actually, these are all prescription. You can read the list. Nutrition absorption is blocking drugs, and these work by blocking fat breakdown and absorption in the intestine. These do have some side effects because they do inhibit the action of intestinal lipase. So the byproduct is bloating, diarrhea, and flatulence. Undigested fat is excreted in feces. Fat-soluble vitamins may also be excreted. Examples are Xenocol and Ally. Ally is over the counter, so you can actually go buy that without a prescription. We have serotonin and agonists. They're selective serotonin agonists. They suppress the appetite and create a sense of satiety. And examples are Belquvic. You can pronounce that. I cannot. Phentermine and topiramate. Phentermine is a sympathomimetic agent, and topiramate induces a sense of satiety. We evaluate the drug therapy for medical conditions. We teach. We teach that drugs are not a cure for obesity. We want to see changes in food intake and exercise and sustained weight loss. We want proper administration. We want to watch side effects and monitor the drugs for appropriate use. Bariatric surgery. This is a viable and popular option for treating obesity. Currently, the only treatment found to have a successful and lasting impact on sustained weight loss for severely obese individuals. And I would say that is for most people that go through bariatric surgery, but I know several people that have gone through it that it has not been successful for. It is life-altering though. Criteria for surgery is a BMI of greater than 40. BMI greater than 35 with one or more obesity-related complications such as hypertension, type 2 diabetes, heart failure, or sleep apnea. You have to be screened for psychological, physical, and behavioral conditions that have been associated with poor surgical outcomes. Illnesses known to reduce life expectancy and not likely to be improved with weight reduction. So you have three broad categories. You have restrictive, malabsorptive, and combination of the two. And this is a visual So we have the top, the adjustable gastric banding, which is restrictive, and that can the restriction can be changed. We have the vertical sleeve gastrectomy in the top center. Then we have the vertical banded gastroplasty in the top right. Then we have the bipancreatic diversion, the BPB, on the bottom left. And then we have the Roux-en-Y gastric bypass, which is on the left, where they actually reroute the intestinal tract. So the adjustable gastric banding is the most common procedure. It limits the stomach size with an inflatable band around the fundus of the stomach. It's connected to a subcutaneous port that can be inflated or deflated to meet the patient's need as weight is lost. This is usually paid for by insurance, and it can be modified or reversed at a later date. And there's a picture of it. The vertical sleeve gastrectomy, 85% of the stomach is removed. It's not reversible. The stomach is functional. Stomach function is preserved. Results in elimination of hormones produced in the stomach that stimulate the hunger, and that's the ghrelin that we talked about earlier. And there's a picture of the vertical sleeve gastrectomy. The Roux-en-Y surgical procedure has low complication rates. It's excellent patient tolerance. Food bypasses 90% of the stomach, the duodenum, and the small segment of the jejunum. And that's what that one looks like. And you can see where they've rerouted. And then we have a combination of restrictive and malabsorption surgery. This can cause a dumping syndrome, as the Roux-en-Y. Gastric contents empty too rapidly into the small intestines. Avoidance of sugary food is recommended. So determining the assisted devices currently in use, the past and current health information and comorbidities, and the risk of complications. A team approach may be necessary. Again, these are obese patients, so we need to evaluate their cardiology or their cardiac status, their pulmonary status, gynecological, gastroenterology. All of these need to be considered to make sure they are healthy enough to undergo the surgery. Preoperative, we still have a room ready for the patient, larger blood pressure cuffs, larger gown, patient transfer equipment, wheelchairs with removable arms, and hospitals that specialize in this do have large beds, large wheelchairs, large chairs in general. We want to make sure these patients know how to cough, deep breathe, turn, and position. So we're going to teach all of this in advance. We're going to teach use of the spirometer. We're going to arrange for CPAP if it's used at home. Sometimes they'll simply bring in their own unit. And we might need to obtain a longer IV catheter. Post-operative, we're going to do close observation for complications. We will transfer with specially trained personnel. We'll stabilize that airway and manage pain, elevate the head of the bed 35 to 40 degrees, and evaluate for resedation. We're going to be especially cautious with these patients while we're turning, and especially while we're ambulating or helping them walk. They're going to have all the complications of any surgical patient. So again, we want them to cough and deep breathe. But they've just had major abdominal surgery. They've got sutures in place. They might possibly have an NG tube in place. We've put gas in their lungs to put them to sleep. We still want that gas to come out. So they've got to cough and deep breathe, but we don't want them to dislodge anything or burst any seams. We want to make sure that we're evaluating their O2 status, Their pulmonary status, we're reviewing them for hypoxemia, for pulmonary hypertension, for polycythemia. They are at risk for deep vein thrombosis, DVTs, for infection, for dehiscence, for delayed healing. They can possibly have considerable abdominal pain. We need to medicate as needed, assess for anastomosis leaks, evaluate any kind of wound condition closely, and that would be the dehiscence. Again, we don't want them to break open their sutures. We want to be attentive to the placement of the NG tube. And remember, that NG tube was placed in surgery. The physician did that while he had scopes in place and cameras in place. If it comes out, do not put it back in. Call the provider, let them know about it. You do not want to be poking that thing down into a fresh belly. When they transition to a new diet, it will be a very strict diet. They've already received pre-op teaching and probably behavioral modification teaching. They know they're going to be coming out and eating liquids for days, eating small amounts. And when I say small amounts, we're talking like a medicine cup is going to be a full meal for them for a while. And they'll do that like every 2 hours. They'll have nutritional supplements that they'll be taking. It is a life-altering choice that they've made with this. So they also have to be cautious of their hydration status. They will be drinking water and sugar-free clear liquids every 2 hours while awake. At discharge, we have to give them instructions on what they'll be eating at home. They should already have this. We'll reiterate that. They'll be on a high-protein liquid diet. They have to eat slowly. They have to stop eating when they feel full, and they will feel full. That will be a change for them, and they can not consume liquids with solid foods. Vomiting is a common complication during this time. They will have a consult with a dietitian. That's part of the bariatric team, and that will assist with the transition to their new diet. One of the things that is common with bariatric surgery is that they go to support groups, and they become part of a group. They support each other. So if occasionally you'll have a patient that just does not want to be a part of that support group, they really have to be independent and follow directions and know how to reach out for help. But that is possible. Okay, ambulatory and home care. Following bariatric surgery, patients find it challenging to maintain a prescribed diet. They now have to have a reduced intake because of the anatomical changes. It is possible for them to go back to their own ways of eating, their old ways of eating, and they will stretch their stomach back out. But this forces them to reduce their oral intake. They may experience abdominal distension, cramping, abdominal pain, and diarrhea. They will have considerable weight loss during the first 6 to 12 months if they follow the plan. And they learn how to adjust and maintain the diet that they've been that they should stick to. They will be put on a low carbohydrate, low fat, and roughage diet, usually 6 small feedings daily. Fluids should not be ingested with a meal, and in some cases, fluids are restricted to less than 1,000 mils a day. They'll have caloric foods, calorically dense foods that are foods that are high in fat should be avoided, and that will allow a better source of nutritionally sound foods. They are watched for things like anemia and vitamin deficiencies. And if they lose too much weight or weight too quickly, that's also a problem. So they're followed for that. They can also have peptic ulcer formations. They can have dumping syndrome. They can have small bowel obstruction. They have to be followed, and they know this. They should not have cosmetic surgery after weight loss until they have their weight has stabilized. Once they reach their goal and they have stabilized their weight. So depending on what their goals are and what they've been set at, they wait to have cosmetic surgery. Again, patients gastric bypass patients need to drink fluids between meals, but not with the meal. A patient, a post-op Roux-en-Y surgery that has an emesis of bile-colored fluid from an NG tube needs to be reported to the surgeon. That would be an indication that one of the anastomoses may have come undone. So with the Roux-en-Y surgery, where they've actually bypassed parts of the stomach, if there's bile-colored fluid from the NG, this gets reported to the surgeon. Let's see. Long-term follow-up care is important for physical and psychological reasons. Issues related to the return of fertility in women. Interesting that comes up. I had a niece that lost a lot of weight after her bypass surgery. And lo and behold, her daughter graduated from high school just at the time she announced she was pregnant. So, yes, she became, and this was after they had gone through fertility treatment because she was not able to get pregnant about 12 years before that. So, yes, you can get pregnant once you lose that weight. All right. Cosmetic surgeries, again, you wait until your weight is stabilized. Ideal candidates have achieved weight reduction, excessive skin folds or fat can be removed. And what do they do with that excessive skin? That actually goes into a skin bank, and it's used for, if it's appropriate, if it's, meets the criteria, it can be used for burn patients. So it's not just thrown out. It goes to a good cause. They can have lipectomies and liposuction that can also help. Here we have before and after pictures. Pretty significant changes in after the surgery. Evaluation. So here are some nursing goals: long-term weight loss, improvement in obesity-related comorbidities, integration of healthy practices into lifestyle, improved self-image, monitor for possible adverse effects. Gerontological considerations. We want decreased energy expenditure contributes to increased body fat. It's kind of a vicious cycle. The more you weigh, the less you feel like doing something. The less you feel like doing something, probably the more you're going to weigh. But this exacerbates age-related problems, decreased mobility, urinary incontinence, hypoventilation, sleep apnea, decreased quality of life, decreased life expectancy by 6 to 7 years. Metabolic syndrome. This is also known as Syndrome X. Insulin resistance syndrome, dysmetabolic syndrome. It's a collection of risk factors that increases an individual's chance of developing cardiovascular disease, stroke, and diabetes mellitus. It's estimated that around 70 to 80 million people, or about 25% of Americans, have metabolic syndrome. It's more prevalent in those 60 years of age or older, and it's characterized by obesity, hypertension, abnormal lipid levels, and high blood glucose. If three or more of the following If you have a waist circumference greater than 40 inches for men, greater than 35 for women, you have active treatment for triglycerides, HDL. If you have blood pressure issues that you're being treated for, or a fasting glucose of over 100 milligrams per deciliter, you may be metabolic syndrome. So the etiology and pathophysiology is insulin resistance related to excessive visceral fat. It's increased prevalence of coronary artery disease that shows up in hypertension, increased risk for clotting, and abnormal cholesterol levels. Here's a little chart for you. Lifestyle modifications are the first line of interventions. Reduced LDL cholesterol, that's the lousy cholesterol. We want you to stop smoking. We want you to stop smoking anyway. We want to see lowered blood pressure, and we want to see reduced glucose levels. We also want to assist with healthy diets, so we educate on exercise, positive lifestyle changes. So exercise, the best form of exercise for folks like this, walking 30 to 40 minutes a day, 4 to 5 times a week. We check patients' blood pressure when determining if metabolic syndrome. That's a big determinant, because hypertension is one of the symptoms. Remember that hypertension is a symptom of metabolic syndrome. Hypertension, increased risk for clotting, and abnormal cholesterol levels. And we also will teach metabolic syndrome patients about blood glucose testing. Those are both things you need to remember. All right, that's it for chapter 41. Thank you.